Welcome everyone to IsisParenting's Breastfeeding webinar, chat, and learn. My name is Nancy Holtzman. I'm a mom and baby nurse educator, board certified lactation consultant, board certified in pediatrics, and I'm the Vice President of Clinical Content and E-Learning here at IsisParenting. With me today is my friend and colleague, Katie, who is a licensed massage therapist and a program associate here at ISIS and is the mom of two. And Katie, I bet you have encountered, unfortunately, numerous sick baby incidents in your mothering career. And that's what we're going to talk about today. We're going to talk about breastfeeding when your baby is sick. I think for most people in the States and around the world right now, it is cough and cold and flu season. And particularly here in New England, the big news has been influenza, the regular seasonal flu, and norovirus, which is a version of the stomach bug that's been getting people down and dirty for quite a while the last month or so. And these things do spread. They come from Europe. They come from the United States. They get across the United States now that we travel so frequently. So unfortunately, moms and parents are going to get sick. Child care providers are going to get sick, which will interrupt your plans for work. And of course, your children are going to get sick. Last week in our breastfeeding webinar, we covered when the breastfeeding mom is sick. And that's a big deal because certainly you need to feel better. You also need to continue feeding your baby. And there's a lot of considerations in terms of your own hydration status, medications that you can take to manage your own symptoms, and so on. So I'll refer you to that webinar. There's a link to that at the end of this one as well, so that you can get some information the next time you yourself have a cold or an ear infection or mastitis or a stomach bug. But today we're talking about keeping your baby comfortable and hydrated, and if your baby does have an interruption of their usual feeding patterns, how to manage or maintain your own milk production. So that's what we'll talk about today. And when your baby is sick, hydration really is going to be your key focus because hydration is important for all humans. I think we are roughly in the about 90% water, 80 something percent water, and because of the surface volume ratios, babies are actually a higher water content than adults. So very small fluctuations in their hydration status can lead to severe situations. So for babies and toddlers, it's really important that they maintain hydration. And most illnesses will have a direct impact on their hydration. So a baby that has a high fever needs additional fluids. Their body uses more fluid just to try to regulate the body temperature. Obviously, if something is hotter, the fluid burns off faster. And then of vomiting and diarrhea. And then, of course, if they have a viral illness, they could have a sore throat, and that makes them fussier about eating. If they have an ear infection, they're going to be more reluctant to eat sometimes. And so all of these things have direct impact on hydration. And we'll talk about, in just a moment, we'll talk about how to make sure your baby is hydrated and what are the healthy signs and what are causes for concern. But I do want to clarify a confusing thing, especially for very young parents, parents of young babies. I know we have a couple of parents in the room who have infants that are just 1 and 2 and 3 months old. And sometimes if it's your first baby, you may wonder, well, how do I know the difference between vomiting and spitting up? Because some babies will spit up and it's a mouthful of milk, and some babies will spit up and it will flow or cascade. And be a significant volume of stomach contents. But the difference between vomiting and spit up has to do with accessory muscle use. So what that means is spitting up is usually it's usually a very passive activity, kind of like a wet burp or just an easy flow of milk that comes up. Now, if it's a large volume of milk, the baby may cough, choke, and splutter after or during the spit up, so it doesn't seem very easy and relaxed. And then also there are some babies who spit up through their nose, and of course the books really don't talk about that. But if it's your first time seeing your newborn spit up milk out of their nose, that will probably freak you out right there. But that's very normal too. Remember that the sinuses drain to the back of the throat, and anything that comes up rapidly from the throat could come out through the nose just as well as it comes out through the mouth. And there are actually some babies who, when they're side lying and nursing and mom has a heavy flow, the baby is drinking milk, and meanwhile, a drop of milk may be leaking out of the baby's nose. That's a separate issue. And seeing milk come out of your baby's nose is normal. But the difference between vomiting and spit up is the use of accessory muscles. So vomiting is more like an involuntary contraction, and you will see sometimes the stomach and the shoulders really get into it, like that retching motion. You know how if you're vomiting, it comes in waves, like 1, 2, 3, and you know there's sort of a contraction of the upper body that goes along with that. Also, when you vomit, you're really feeling crappy, and so there's distress involved. Nobody just sits there and happily vomits, including a baby. A baby will lie there and just let milk spit up. And we call that a happy spitter. But vomiting is different. If there's food involved, sometimes vomit has a bad smell to it as opposed to spit up. And the reason I mentioned frequency is because all babies will have the occasional projectile vomit, and that's when milk comes up with great force and shoots out of the mouth, kind of like Exorcist Baby. And that doesn't have to mean anything. So you might pick up your baby a certain way, or it just can happen like a random fluke thing just to freak you out. But you should be concerned if your baby projectile vomits 3 times in a row. In other words, they projectile vomit, you try to feed them, the milk comes shooting out again in 5 or 10 or 20 minutes, and then it happens again. So if almost all the milk that's going down eventually comes back out in a projectile vomit, and your baby is, well, that's always a call to the pediatrician. But typically in a baby that's under 6 months old, that's usually a pretty significant sign of pyloric stenosis, which is a tightening of one of the valves that leads from the throat to the stomach. So that's a not uncommon scenario, but that's a call to the pediatrician if everything that goes down is coming back out rapidly like a projectile vomit. And then the other reason I put frequency concerns there is if you're home with your sick baby, whether your baby is 4 or 8 or 14 or 18 or 25 months, and pretty much they're not keeping anything down. You're trying to feed them sips, you're trying to feed them a concern. That's a call to the pediatrician. It's okay for a baby to take tiny little bits, to take a spoonful here and a slurp or a sip here, but they need to be able to keep some of that liquid down. Loose poop versus diarrhea, that's another one that's hard for new parents to tell. One thing to consider is that when a baby is not feeling well, he or she may want to nurse more often. If they're older and eating solid foods, they may be off their solid food and just want to nurse. And so a baby that formerly had been having more chunky poop or thicker stool may go back to the very liquidy breast milk poop of the early weeks and months. And that may be a surprise if your baby is 9 or 10 months old and you haven't seen poop like that for a long, long time. You may think of it as diarrhea. But if your baby is almost exclusively getting breast milk again for a couple of days, expect that they're going to have that very loose, runny poop, and that's just that plain old breast milk poop. But diarrhea typically smells bad and is not well contained by the diaper, and it's also very watery. So breast milk poop may be liquidy, but it's like liquid yellow paint or mustard or yogurt consistency, etc. But it's not watery so much. Also, diarrhea can smell a little bit fishy or foul, and generally that's the answer. It's watery mixed with solids, and it's not contained by the diaper, and it smells bad. Whenever a baby is not eating well and has a fever, you want to monitor for wet diapers. A minimum of 4 in 24 hours. That's pretty much the standard that we use for pediatrics, but I would say for a baby under 6 months, I would even be more cautious. So I would really be hoping for 5 to 6 wet diapers, but four wet diapers in 24 hours is usually sort of the cutoff that we use to say, okay, this baby is adequately hydrated. These are not necessarily going to be the heavy soaked diapers that you're used to, but they shouldn't be so dry like day 3 of a newborn where you're struggling to try to determine whether or not the diaper is wet or dry. These are clearly wet diapers, but there should be at least 4 voids in 24 hours. Good signs to look for in a sick, feverish baby who's not eating or drinking very well is to make sure that the eyes look glistening. If the baby does cry, there should be tears, but most importantly, the baby should have that nice, wet, juicy mouth and be playful or smiling. That actually is a very good clinical sign. Concerning signs of dehydration would be a baby who is very sleepy, listless, is not keeping any foods or fluids down, isn't wetting diapers. These would be things to be concerned about. Again, the mouth doesn't look moist. The tongue or the lips are starting to look dry or cracked. No tears when the baby cries. That's concerning for a baby who is starting to show tears. Often under 6 to 8 weeks or so, you don't really see tears when a baby cries. And I just wanted to mention the sunken fontanelle business because that's always listed as a sign of dehydration. That is a very late sign of dehydration. And things like the juicy mouth, the baby's diaper output, those are much better things to be watching for. And it's also normal to have a sunken fontanelle, a depression in the fontanelle. The baby's head, the soft spot, it does have an indentation. So a lot of times parents don't really pay a lot of attention to the fontanelle until they're looking for the sign of dehydration, and then they see it actually does dip in a little bit, and that freaks out the parent. So everybody later today, take a look at your baby's fontanelle and notice that it does dip in a little bit, and if your baby does not have a lot of hair, you'll also notice that it has a pulse, and all those things are normal. Okay, so what do you do to keep your baby well hydrated? It's okay if your baby is temporarily not interested in solid foods. You want to mainly focus on hydration if that's what they're interested in. If they do want to eat, by all means, you can go ahead and feed them, even if they are vomiting. As long as they're keeping a little bit down, that's okay. A lot of the common baby foods like pears and applesauce and sweet potatoes and oatmeal and things like that have a very, very high water content. So you can give your baby half a jar of applesauce if that's what they want, and know that that also is helping to keep them hydrated. For an older baby or a toddler, you can try things like Italian ice or Jello. Jello, although it looks like a semi-solid food, it's actually liquid. And then popsicles, and some people will call frozen breast milk momsicles. So you can make a momsicle, like take a cube and make a cube of frozen breast milk and put it in one of those mesh feeders, which of course everybody in the chat room knows I call, they'll type it in. And so that's another way for a baby that has a sore throat or a little bit of a fever to have a little treat. You don't want to give things like apple juice full strength or ginger ale or Coca-Cola to an infant or a toddler with diarrhea or vomiting, because the high sugar content can actually make the diarrhea worse. If your older baby is drinking juice on a fairly regular basis, I hope it's dilute juice, if so, and that also can continue to be offered dilute. If you call the pediatrician's office and they say, oh, your baby's vomiting or your toddler is having diarrhea, well, give Pedialyte. I'll just mention here that if you are breastfeeding and or have breast milk, you don't need to give Pedialyte. Breast milk is a better hydration solution. Even if it's coming back up, some of it stays down. And Pedialyte is essentially something that's given to formula-fed babies. They often will interrupt the formula for 12 or 24 hours and give Pedialyte wait until the vomiting or diarrhea is better, and then reintroduce formula, sometimes half strength, and then going back to full strength. But if you are breastfeeding directly, or if you're typically giving breast milk in a bottle or a cup, you don't need to switch and stop breast milk and give Pedialyte instead. If your older child is interested, you can offer Pedialyte in addition to breastfeeding, but you don't need to interrupt the breastfeeding to switch over to an electrolyte solution, which they would recommend if you were formula feeding. But sometimes in the pediatrician's office, not all of the triage nurses, or sometimes even all of the pediatricians, are fully familiar with the breastfed baby, and so they will give just very standard information like stop giving the milk bottles and give Pedialyte instead, and that may not necessarily apply to you. In this orange box here is a recipe for homemade rehydration solution. Like a 6-pack or an 8-pack of the small containers, because once you open a container, it needs to be used within 24 hours. So if you get the big one, you're not going to use it up and get the smaller ones. But you can easily make a hydration solution at home. Take a 1-liter bottle and you just add carefully measured this amount of sugar and salt, and that makes a balanced electrolyte solution for rehydration, and that works for older babies and toddlers and adults as well. You can add a splash of juice for flavoring if you'd like. Okay, so this is probably the most common issue that parents have to deal with infants and toddlers, and particularly with young babies. They just always sound so congested, and especially in the winter, those of you with the youngest of babies need to remember that infants are obligate nose breathers, so they have a very strong, clear preference to breathe through their nose. That leaves their mouth available for all of the sucking that they like to do 20 hours out of 24 hours. In order to keep their nose clear, they make a lot of mucus. So it's very normal for your baby to sound stuffy and schnurgly, and to see mucus draining, clear mucus draining from their nose on a regular basis. And when they lay flat at night, you'll hear them sound very congested because that mucus is now draining down the back of their nose, and it kind of collects at the back of the nose or the top of the throat, and it makes them sound very, very schnurgly and mucusy. In the winter months, if you live in an area where the heat is on, that makes the house dry inside, and it's really, really beneficial to have a humidifier going. You might think of a humidifier as sort of an extraneous, nice-to-have item, but I would suggest to you it's amazing how much a humidifier can actually help a baby sleep during these winter months as well, because the dry air makes the baby more congested, makes the baby more thirsty in the middle of the night, and it dries out the skin too. And of course, we mentioned that babies and toddlers have very high water percentages in their bodies, and so they really react to the change in the humidity of the air they're breathing. So it's a humidifier running, no decongestants if the baby does have a cold. No cough and cold medicines are really recommended at this point anymore. You do want to use the saline drops and a nasal aspirator to loosen. So the saline loosens and lubricates the sinus passages, and it makes the mucus easier for you then to schnurgle out with the nasal aspirator or the nose Frida. And the nose Frida is kind of this weird nasal aspirator that has kind of a cult following. The thing with this is the reason it kind of freaks people out is because it's the mother's own mouth that creates the suction, but there is a filter, so there's no way that you can suck through the tube and get the baby's mucus into your mouth. But just, the whole connection there between the baby's nose and your mouth definitely freaks people out a little bit. But people that use the nose Frida love, love, love it, and certainly the baby finds it less traumatic than the nasal aspirator. But these two things go together like salt and pepper. You shouldn't be using the nasal aspirator without first putting in a few drops of saline, and you don't spray the saline in the baby's nose. You just put a couple of drops there. Use caution if you're told to have your baby sleep in the upright position, like elevating the head of the crib. There's really no safe way to do that. So it's a common recommendation, but it's not recommended. Even the American Academy of Pediatrics recommends against elevating the head of the bassinet or the crib. And here's why. If you try to put something under the crib mattress to tilt the mattress up, that can create a wedge or a gap within the mattress, and the the crib frame, so that can lead to suffocation or entrapment. And if you try to put the legs of the head of the crib or bassinet elevated with books or something like that, either way, babies just don't stay put when they're sleeping at night. And so if you elevate the head of the crib, it's not really going to be beneficial anyway. They're going to inch or scooch or pivot or roll down to the foot of the crib. And for a very young, small baby like a bassinet, if you tilt the bassinet and the baby rolls by accident to the bottom or the foot of the bassinet, you have a suffocation hazard there. So I really don't recommend elevating the head of the crib or the bassinet. If a baby is really congested, sometimes having them sleep in an upright position, which would be like the infant car seat or a bouncer seat with the belt secured and on the floor. Swallowed mucus I mentioned because when a baby does have a very goopy, congested nose, they'll swallow that mucus, and then two things will happen. It will either irritate their stomach and they'll spit up or throw up and you'll see mucus there, or it will pass right through their digestive system along with their milk and or food, and it will come out the other end. So you will actually see green or yellow mucus in the baby's diaper if they're swallowing that mucus. The digestive tract is a mucus membrane, so it makes mucus. It doesn't digest mucus, and so the mucus is going to pass right through from the baby's nose to the belly, through the GI tract and out the other end, and then sometimes, as I said, it irritates the baby's stomach and the baby will throw it up. Lovely. Okay. After congestion, I think the next big concern that parents have taking care of their little ones is fever. And I was answering a lot of fever questions on Twitter over the past few days. And I think we need to also clarify exactly what a fever is. And clarifying what a fever is depends on where you're taking the baby's temperature. Also, I answered a lot of questions about tympanic membrane thermometers, or the ear thermometers, or the temporal thermometers. And the reality is, in the home setting, the most accurate way to take your baby's temperature is a rectal thermometer, a digital thermometer, the same thermometer that you see here in the baby's armpit, with a little bit of lubrication on it. And that's how you take a baby's rectal temperature. It's very quick. It's painless. The thermometer goes in about an inch and no more. It doesn't hurt the baby, and you can do it right on the changing table. But you don't need to do a rectal temperature every single time you want to check your baby's temperature. That's when you need an accurate reading, and that's the time that you're going to call the pediatrician because your baby's sick. Before you call the pediatrician's office, take that rectal temperature, because that's what they're going to want to know. But in between, if you know your baby's got a fever and you're giving them Tylenol, or you just want to check in on them, you can do this axillary temperature under the armpit, which is also quick and painless and easy to do and a little less invasive. But the ear thermometers are really not recommended for children under age 1 for several different reasons. You're not going to get as accurate a reading because babies have very short and also tilted ear canals, so it's much harder to get to the tympanic membrane for accuracy. And also the temperature readings can vary dramatically depending on the baby's position. If you check the baby's ear temperature and they've been laying on that ear and there's more blood flow to that area, the temperature can actually be elevated more than a full degree. So rectal or axillary would be my recommendation, and I think most pediatricians would heartily agree with that. They really roll their eyes and don't want to hear very much about what your ear thermometer or temporal thermometer said. Remember that oral temperature normal is 98.6, but we don't take an oral temperature on an infant or a young toddler. So you'll either take an axillary, which is 1 degree cooler, or a rectal, which is 1 degree warmer. So remember that the rectal temperature temperature. So I had a mom on Twitter this morning say she was telling me about her baby's fever, and she said the baby's temperature was 99.1 rectal, and you know, we had a little conversation about normal temperatures. So the baby's temperature yesterday had been 101 rectal, so we were both pleased to see that the temperature is coming down. So here is a little reminder as to the rectal temperatures. Basically, I like to say 101, but I know that a lot of pediatricians have the cutoff at 104 or 106. For a baby under 3 months old, I would certainly call the pediatrician with any concern over a temperature. And if you're a first-time parent, then you should call the pediatrician with any concerns about a fever for your baby of any age, because you haven't had enough experiences yet with babies with fevers not to be nervous about it. Babies do tend to end up with higher fevers than adults. So if we had a fever of 102 or 103, we would feel like we were at death's door. We would be calling in sick. We would really be bummed. And yet for a baby to have a rectal temp of 102 or 103, they'll have that with a run-of-the-mill virus. And in between, they often will they'll act a little different, a little under the weather, but they still may be quite cheerful and playful with a temperature of 102 rectal. I'm going to talk about medications on the next slide. So giving meds, this is tricky, and another one that I spend some time explaining to people. Know what medication you're giving. I was just in CVS this morning. I was looking at all the various medications, and I wanted to I was surprised but pleased, I guess, to see that you can still get the infant acetaminophen or Tylenol drops. So it's not the brand name Tylenol. I think they've stopped manufacturing that. But PediaCare and CVS brand and so on, you can still get the 180 or 160 milligram in 5 ml drops. But make sure you know what dosage you're going for. And it was very confusing for a layperson, I thought, in CVS to look at all of the different fever and pain relievers. And they have the acetaminophen and the ibuprofen mixed together. So you really need to read your labels and see what you're getting. Acetaminophen is the brand name Tylenol, but of course there's other brand names. And ibuprofen, the brand names are Advil or Motrin, and then of course other brand names or generics. These are two medications that are different. They have different dosages, and if directed by your pediatrician, you actually can alternate and give acetaminophen, and then 2 or 3 hours later ibuprofen, and then 2 hours later acetaminophen, and so on. So if a baby is very uncomfortable and has a high fever, sometimes we'll alternate between those two dosages, but always find out what is the milligram you're supposed to be given based on your baby's weight and milligrams, and what does that translate to in the concentration that you have. So you need to do the math yourself and figure out that, making sure that you have the right milligram dosage in the volume given. The Feverol suppositories I want to call your attention to, because that is such an easy way to give a baby a Tylenol. The brand name is Feverol, but they're acetaminophen suppositories. It's so easy to give the baby a suppository right on the changing table. Doesn't hurt them. You're not going to force it in, and you just poke it right in there, and it just gets gobbled up by the butt cheeks, essentially, and it's absorbed very, very quickly. It melts right away in there, and it's absorbed fast, and there's no risk of the baby spitting it out or puking. So if a baby is vomiting and has a fever, it's a great way of medicating them. When you want to give a liquid medication, whether it's Tylenol or Motrin or an antibiotic, use a medicine dropper like I have pictured here, or an oral medicine syringe, and you draw up the complete dose, and you're going to give the dose half at a time, and lay the baby across your lap. Use your finger to pull the corner of the mouth away, and you want to put the medication in the cheek pocket way back where the molars are going to be. So not in the middle of the tongue, not squirting it in the mouth, not letting the baby suck it out of the dropper unless they've proven to you that they love the amoxicillin or they love the grape flavored Tylenol or whatever, because the bigger issue is that you give them the medication and they either gag and vomit it out, or they tongue thrust and spit it out, and then you're not sure how much of the dose they got. So again, it's just like giving a dog or a cat a pill. They're across your lap, the head's tilted back, pull the corner of the lips away, insert the dropper or the medicine syringe, squirt half the dose into the cheek pocket. Then you're going to use your hand to push up on the chin, close their mouth, hold their mouth closed until you see them swallow twice. That usually takes about 10 to 20 seconds. Obviously, you're not obstructing their nose, but you are holding their mouth shut until they swallowed twice. Then you can relax, praise them, do the other half of the medication, same way, then you're done. Okay. Moving along, coughs. Coughs take time. So a baby may have a cough for a full week or two after an illness. Different types of coughs. You can have a croupy cough. You can have a wheezing cough. You can have a deep cough in the chest. If the sound of the cough concerns you, call the pediatrician. But generally, if the baby doesn't have a fever and the cough is not frequent enough that it's waking them up several times at night, usually the cough will pass on its own. But really, it can take 1 to 2 weeks before the cough is gone. Some really nice research on using honey for coughs. And of course, this is for babies over 12 months of age, because before 12 months, we don't give honey to babies in uncooked products because of the risk of botulism. But 1 to 2 teaspoons of honey given at bedtime, and then brushing your baby's teeth, because of course that's pure sugar. The honey actually does reduce the frequency of night coughs and wake-ups. And I put a link right here to this research study that was published in the Journal of Pediatrics. And it may well be that your pediatrician doesn't know about this study that only came out a few months ago, but now you do. Also, I put these other pictures here because the dry air can cause a cough or cause a cough to linger, so remember to use your humidifier. And then sometimes babies that have runny noses will have a lot of coughing as well, or coughing at night because of the postnasal drip. So again, the saline and the nasal aspirator can help at bedtime too. Some more information. These are links, live links that you can click on. Three articles. Sick with a cold, so meds for moms that have colds. And then these two here, managing colds, flu, and fever, and managing GI symptoms, are articles that cover handling those situations when you're pregnant. And then another section on if you're breastfeeding, and then another section on handling those issues for an infant or toddler. And then last week's webinar was when the breastfeeding mom is sick. And then these are all live links here that are for resources for checking out medications, essentially medications in mother's milk, which I go into in more detail in the When Nursing Mom is Sick webinar. Okay, hopefully your baby will continue to breastfeed throughout their illness, because that will keep them hydrated and comforted and keep your supply fine. In fact, sometimes they want to nurse more. If they're a toddler, for example, they may not want to eat, and they just may want to nurse like they were a newborn again. And so you may be dealing with a little bit boosted over what it had been. But if, for example, your baby is not eating well, remember that one way or another, you do need to be moving your milk. So you want to keep moving that milk, or otherwise you're going to lose that milk. Depending on the age of the baby, somewhere between 5 to 8 times in 24 hours. So if you have an older baby, maybe six months through toddlerhood, I would recommend expressing milk 5 times in 24 hours if, say, you were away from your baby on a business trip or something like that. And then if you had a newborn who, for whatever reason, isn't nursing well or latching or transferring milk, then 8 times in 24 hours would be what I would suggest to manage full milk production. So you can use those guidelines to determine how frequently you should be expressing milk if your baby is not feeding well. But remember that if you're sitting around with full breasts and the baby isn't feeding and you're not moving that milk, that can begin a downward regulation in terms of your own milk production. Navigating the doctor's office, and if a baby is hospitalized, I guess, what I wanted to say about that, it's sad, but there's a picture here of mom and baby in a crib in a croup tent, and that's fairly common. Sometimes a younger baby may have RSV, or a slightly older baby may have croup, or a baby may be dehydrated, and you may end up, it's not common, but you certainly could end up hospitalized. And typically in that type of a situation, the mom is able to stay with the baby. They usually give you a pull-out cot. You don't have to be in the crib with the baby, but in a croup tent, the baby is kind of under this vented plastic wrap that keeps the air moisturized. And so to keep the baby happy and calm, sometimes parents do kind of climb in there too. The baby should be nursing, but if the baby isn't nursing, or if for whatever reason they require that you interrupt nursing, then you need to be expressing milk. It's, in a larger hospital, you can ask to speak with the lactation consultant, and sometimes they can navigate for you. If, for example, a child needs surgery or something like that, typically they'll give you the protocols. You're usually allowed to continue breastfeeding up to 1 to 2 hours before the surgery and be there in recovery and so on. So the lactation consultants in the hospital can help navigate. I would absolutely bring your own breast pump. Of course, the hospitals should have breast pumps, but how you can get it and how it works for you and so on. If you know that you're going to the doctors, or they call and they say, no, it's 11 o'clock at night and your baby's a little dehydrated, you should go into the emergency room, bring your pump with you just to know that you have it. If you do need to express milk, here, as many of you know, I always encourage the hands-free double pumping as the way to go. Wrapping up, keeping yourself healthy will help keep your baby healthy. I wanted to manage expectations here. It may seem like from 6 months onward, your baby is sick about 50% of the time, and that is because babies typically do get 6 to 8 viral illnesses in a year, and each viral illness can last a week or longer. And so it may seem like they have a runny nose, they have a cold, they're sick with a cold or a fever, they're getting over that one, they have a day or two where their nose is less crusty, and then they start getting sick again. That's what it can feel like. That's why I said if it's the first time your baby's been sick, call the pediatrician, get that reassurance. But unfortunately, it won't take too long before you're a little bit more old hand at this. A lot of times parents are concerned that the pediatrician doesn't seem as concerned as they think should be. The baby's had this bad cough for 5 days, or the baby has a temperature of 102. As I mentioned earlier, give them a call. Hopefully they have call-in resources, whether it's a triage nurse or an on-call screening or something like that, where you can call and ask questions and either get a call back or someone will be able to answer the question. And I would never be, well, I shouldn't say never, I wouldn't be eager or in a hurry to bring the baby into the pediatrician's office to get checked out. So if they say, well, monitor this at home and call us back if this, and this, I wouldn't necessarily push to go in and be seen unless you were really worried, because most of these illnesses are viral illnesses, and there's really no medication or antibiotic that they can give you to make the baby better. It's going to be hydration and fever management if the baby isn't comfortable, and the tincture of time. And if you ask me where is the germiest, sickest place in town, I would say your pediatrician's office this time of year. So you go in for one reason and you come out, with another festering infection. So keep your hands clean, wash your hands constantly, use hand sanitizer when you're out and about, get your own flu shot. If your baby is over 6 months old, I hope they've had their 2 flu shots. If it's their first year, they get 2 a month apart. If your baby is in a child care setting, they have protocols in place about babies should be without a fever for 24 hours and so on. But, just be prepared. You will get calls that a baby had RSV, or that conjunctivitis is going around, or a GI bug is going around, or, lice is going around. This happens. And, that's how in the formal setting, in the daycare centers, you'll hear about it. But even when you go to the supermarket, even when you go to the library story time, or, play group at a friend's house, this is real life. There's germs everywhere, and infants and toddlers are very joyful at sharing their germs, and it does stimulate the immune system. Okay, join us next week. Next week it's going to be all questions for the whole half hour, so 30 minutes of Q&A, and that's what we'll do. Let me see if there is a quick question or two I can get. I'm going to take this one because this mom was in early. She put her question right up there. She's number one. So if I can get it. My 8-month-old takes 2 6-ounce bottles at childcare, in addition to nursing 3 times a day. When I pump at work, he gets the bottles. I'm unable to pump 6 ounces each session. Yes, that's a lot of milk. I can usually pump 4 or 5. I'm worried about production. Is the amount I pump really true to how much I give him when I nurse? No, it's not. I notice that on the weekdays when he gets those bottles, he tends to sleep better. On the weekends when I strictly nurse him, should I supplement with breast milk? Blah, 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 blah. Okay, this is a long, long question. I can't get through the whole thing because it cuts off the paragraphs. But there's 3 different things. So I always try to explain it this way. There's how you nurse your baby when you and your baby are together. There's how your baby drinks bottles when you and your baby are apart. And then there's how you pump milk when you're at work. So those things are unrelated yet interrelated. So for example, during the typical 10-hour separation, so you work from 9 to 5:30 and you've got a half an hour commute on either end, so you're away from your baby for 10 hours. If you are home during that 10-hour period, you might nurse your baby 6 or 7 times before nap and after nap, while or 3 discrete feedings or 3 feedings plus a meal of solid foods. At work, you're going to pump 3 times. They may not be the same the same times that the baby would be getting a bottle in childcare. They certainly wouldn't correlate with the frequency or the timing of how you'd breastfeed at home and so on. But ultimately, roughly, the volumes of milk should be in the ballpark. Now, babies can drink a lot more milk from a bottle in one sitting, and sometimes they will drink, he's drinking these 6-ounce bottles. Probably if you put 6.5 or 7 ounces in there, who knows, he might drink that too. But that doesn't necessarily mean that he absolutely needs that volume of milk, and it certainly doesn't mean that that's how much milk he takes when he's nursing. And when you pump milk and you pump 4 ounces, that doesn't mean that that's the only amount he gets when he nurses either. If you feel like you need more milk, what I would suggest is expressing in the evening before you go to sleep, because your baby is older, 8 months old. He's probably going to sleep at 7 or 8, in that range, 7, 8, or 9 p.m., and you're probably staying up for a couple hours later. And so maybe if you pump one more time before you go to sleep, you can stash away a couple of extra ounces to supplement what you're pumping at work. But my other suggestion would be to move forward with solid foods. Use carefully selected, high density, high nutritional and caloric value solid foods, and let them in childcare offer him 2 solid food meals a day, breakfast and lunch, and so on. And he may not ever need more than that 6 ounces in the bottle if he's starting to get a bowl of cereal and fruit in the morning, and then a bowl of cereal and a vegetable and a fruit or a protein food in the midday, and so on. I would refer you to the childcare. There's a webinar that's called Childcare, Caregivers, and Breastfeeding, and I talk in that one about introducing and advancing solid food for the baby in childcare when breast milk is scarce. Your breast milk is not scarce, by the way, and I don't think you have a supply concern. And at 8 months, I think you're doing just fine. And I would just the breast milk intake is going to stay stable at this point. He's not going to increase. He's not going to need more milk than he needs right now. But you want to make up the difference in terms of high value solid foods. Okay, I see it's 1:15, so I've already gone over our time. I'm going to wrap up for today. I'm sorry I couldn't get through all the questions, but next week we're going to do all Q&A, and there are 45 different breastfeeding and pumping topics on our breastfeeding webinar archive page. You went to that page to click through here today. If you scroll down, you'll see all of those different topics listed. And if you have a specific question, you'll probably find a webinar that addresses it. I will also be back on Tuesday at 12 noon with our sleep webinar. And this coming Tuesday, Meg and I are going to talk about pacifiers and infant sleep, the good, the bad, and the ugly. So a pacifier water is a wonderful soothing instrument, and sometimes it can become a little bit problematic as well, and we'll talk about that on Tuesday. I hope you all have a healthy week and keep yourselves and your babies healthy and happy, and thank you all for coming today, and I will see you on Facebook and on Twitter and in ISIS Parenting Centers, and thank you, Katie, for being our moderator today. Bye, everybody.